this week, last week, I don't know, those of you who joined heard about my little meltdown on one of the days. But this week has brought about more uncertainty and, you know, specifically political discourse. And after my little meltdown, I made a more concerted effort this week to shield myself from the news, especially at night and in the morning when I find it affects me most. So it either kind of subconsciously affects me during the day, like with this kind of undertone of fear or dread. I always feel like there's this kind of undertone going on, or it would affect the quality of my sleep. And I think there may be some of you who are saying to yourself, no, it doesn't bother me, it's okay. But remember, there's a lot going on with our subconscious mind, so that we're not aware of. So you know, I've been trying to shield myself from a lot of this kind of non-stop 24-hour news. On the travel front, we've had some good news with the Canary Islands being added to the safe corridor list, so no quarantining required. So that's good news. And also the Maldives. I was looking this week at where people are traveling to, the people who are booking with us, and it's no big surprise. It's those places that you don't need to quarantine, which are St. Lucia, Cyprus, Madeira, Greece, and obviously the UK breaks that we're taking as well. So coming back to setting ourselves up for a good night's sleep, one of my tools is that when I am lying in bed, I run through all the things that have happened during the day that I'm grateful for. And it could be really big things or small things. So it could be seeing a specific bird on my walk, or having a wonderful conversation with a client or a family member. Well, last night I started to think about what I was grateful for. And my dear friend, Dr. Stephanie Goodwin, popped into my mind. And I felt very grateful for getting to know her. And not only has she been very helpful in my own journey with my hormones, and I've got to tell you, I feel like I've got a really close relationship with my own hormones. But she's also very inspirational in how she lives her own life, and as I said, has become a great friend. So this clever lady is an excellent doctor by day. But Steph, I'm going to let one of your secrets out of the bag. She is a jazz singer and musician by night, and is a brilliant performer. So she inspired me to pick up the piano again after so many years of not playing. And we share the joys of talking about scales and jazz chords together. So Steph, welcome. Where are you? Oh, speak, say hi so we can hear you.
I'm here, Stella, I'm here. I'm here.
Good. So happy to have you with us.
I'm delighted to be here. Thank you.
Oh, bless you. And I want to start by coming back. I used the word empowerment when I talked about like why we started our Wellbeing at Home sessions, but I think it's really specific for women in particular, especially around this subject. And that's what you do. You really empower women with information and evidence. So by complete coincidence this week, it was World Menopause Day. We didn't plan it that way, but in the past, nobody even talked about menopause, right? And it wasn't even kind of considered a medical condition. Can you just give us a bit of background about that?
Well, first of all, thanks for inviting me, Stella. It's lovely to be here. And also I feel very blessed to have met you. So I'd just like to share that as well. And also I think you look like you're in the White House with your emblem behind you. That's really amused me.
That has become my emblem.
In the Oval Office. So yeah, World Menopause Day. How great is that? Because it has been a subject that has not been discussed, because the menopause is not a sexy subject. And I think a lot of women feel uncomfortable about discussing it. It's a bit too much information. Most women previously had felt that it was something that you just had to shut up and get on with. But I think because so many women have suffered a lot, and because women want to continue to enjoy and be engaged in life and work and so on, that actually action has needed to be taken to keep women feeling really well and strong from, you know, perimenopause and menopause onwards. So there's been a lot of work to encourage education for women and doctors. And it's actually a really exciting area of medicine to be involved in. So it was great to kind of celebrate it. And so it's something that we all, as women, no matter what else we may or may not have in common, we're all going to go through the menopause at some point. So it's a sharing thing for us.
Yeah, so true. So very true. So you've done, I mean, what made you want to specialize in this? Because you've done a lot of work on it and you've been awarded the Advanced Certificate of Menopause Care. And I know you do a lot of specialist work and you're always learning more and doing, you know, kind of more detailed work on it. What drove you to get into that?
Well, I think probably about 10 years ago, when to be honest, I didn't really know that much about the menopause. I don't think I did any undergraduate training. I knew, of course, I knew a bit about it because I've been a GP for, God, I don't even know how many years, 25 years. But I realized that more and more of my patients were entering that phase of life because all my patients were all growing older together. So it was my patients, my friends, and myself. And I just realized that I didn't really know enough about it. So I started doing some extra training. And in order to do so, you have to go and work in a menopause clinic. So I did that at Guy's Hospital as a volunteer in order to do the basic menopause training. And I just found the clinic really fascinating. The stories for the women that I was meeting, some of whom had straightforward menopause, but some were very complicated because it's a specialist clinic. And so once I'd done the basic certificate, I then thought, you know, I'm really enjoying this. So I asked guys if they would give me a job, but employ me, which they very kindly did. And then because I was doing so many more sessions, that meant I could then do the advanced certificate, which means you have to do a year's work in a clinic and write a dissertation and so on. And I just find it a very, very rewarding subject because it changes women's lives. And the evidence coming through all the time is about the benefits of helping women through this transition and the benefits of using hormone replacement therapy. So I just felt it was my duty to find out as much as I can so that I can give the right information to women so that they can make a choice for themselves based on proper facts and not what I perceive to be fiction, really.
Yeah, that's great. I mean, I think you're absolutely right about it not being spoken about. And even, you know, certainly women of a certain generation, our generation, I remember talking to my mom about it, and she just almost refused to tell me anything. And I think that comes from her generation. Or maybe she didn't think it was a big deal. And I remember her suffering through it. I actually remember the suffering that she had, but she didn't, you know, she just kind of brushed it under the carpet. And I think it was the mindset in those days of just get on with it. You know, why are you making such a big deal out of this? Get on with it. So, you know, thank you for driving this message forward. I know there's a lot of talk out there right now about menopause, and, you know, and lots of websites and, you know, lots of people talking about it, which is great because it's all about empowering women. Now, you know, we talked about this a little bit before. We have quite a wide range of women who join our sessions in terms of age. So I know we've got big subjects to cover. It's like lots of different phases in the women's life. And what we're going to try and do is cover a little bit on perimenopause, menopause, and then post-menopause. Please feel free to put your questions in chat like you usually do, and then we'll stop periodically. Steph can answer them. But if we start with perimenopause, when does that, at what point in our lives does that usually start, and what are the main symptoms? Because I personally know that I was going through symptoms and I didn't even know I was perimenopausal. I didn't, you know, it was not till many years later that I realized, oh my gosh, those were my hormones. That was my hormones. And I want as many people as possible to know about this so that they don't think they're going crazy at the time. Yeah.
I mean, I think so. The first thing I would say to people is, is just to establish a few definitions, because that puts it into context. So menopause just means you've not had a period for a whole year. So that's a definition. Menopause, no period for a whole year. So some women don't know they're in the menopause until a year later, because they suddenly realize they've not had a period. And the perimenopause is the time leading up to that. So that it's very variable. I would say on average, it's about the age of 45, because the average age of the menopause in the UK is 51. So women will start having, or may start having, symptoms from their mid-40s onwards, when you're probably not expecting it, which was probably what happened to you, Stella, and it was what happened to me.
I think it actually started earlier.
Do you?
Is that possible?
Yeah, absolutely. So, I mean, there's a proportion of women, 5% of women will hit the menopause at the age or before the age of 45, and 1% of women will have menopause before the age of 40. And so we see women in the clinic I do at Guy's who are menopausal at the age of 25. So, but it's unusual, but it's not impossible. And so the symptoms are very variable, but the ones that tend to creep in that you're not expecting are often mood changes. So it can be anxiety, poor sleep, poor concentration, brain fog. So often the initial symptoms are a bit more the psychological ones: depression, irritability. And often what happens is that women might go and see their GPs about it, and they get prescribed antidepressants, which is not the right treatment for women of this age. And therefore, they not only do they not take the treatment, but they never go back for any more advice, because they feel that they've been fobbed off. And then you may start to get irregular periods, either less frequent, more heavy. So there can be menstrual changes. You can start to have what we call vasomotor symptoms, which are hot flushes, which occur during the daytime usually, and then sweats, which can be at night. Muscle and joint symptoms, so muscular pains, change in libido. It can go down, it can go up, but more women would complain of loss of libido. And then vaginal symptoms, dryness, soreness, urinary symptoms. So really it can affect your whole body. And what I want women to know is that it's not just about one symptom. So sometimes what takes a while for the penny to drop, not just for women, but for doctors, is that you've got to look at the bigger picture, and you've got to join the dots together. And then you might think, okay, well, maybe I'm now perimenopausal. So UK average for perimenopause is about 45. But as I say, there's lots of symptoms. So probably over 40, but the ones I've spoken about, they're the most common ones.
Right. I'd just like to add to that list, memory loss.
Memory loss, yeah.
And not being able to sometimes even think of the most simple words. Yes, forgetfulness, Cara, exactly. It's the same thing. So what can we do about that? Because I've had lots of conversations with you about this, and just to give everyone a little bit of a backdrop, I was very anti-HRT because I like to do everything very naturally. And Steph had helped me through my own personal issues. And so I've had lots of conversations with Steph about HRT, which were very enlightening for me, which I'd like you to share with everybody, please.
Yeah, sure. So I think the number one thing is knowledge, because if you have the knowledge, then you can make up your own mind about what you want to do. So the first thing is to be aware of what symptoms you're getting and where you are in life and how you're feeling. And just remember that it might be due to perimenopause. In terms of managing it, it's a very personal choice. I prescribe HRT treatment a lot because the benefits of it are so massive, basically. And we'll talk about alternative treatments, and alternative treatments might relieve your symptoms, but they won't give you any long-term benefit. So what I say to people is that the menopause is just nature's way of stopping reproduction, because we wouldn't have got to the age of 50 from an evolutionary point of view. We would be dead by now. So certainly I would, probably. But anyway, so we would be dead by now. So nature has stopped menstruation to stop reproduction because we would be dead. So we're left with 30 plus years of being in a state where our bodies have no hormones. And really every part of our body depends or benefits from having hormones. So hormone replacement therapy is just putting back a little bit of what was there before. It's very small amounts of hormones that are identical to the hormones that we take in our that we make in our own body. So the benefits are massive, and the number one thing really for me is symptom relief and being able to function. So I know that for myself, if I didn't take HRT, I would not function, because if I forget to take it, which occasionally I do, within 24 hours, I can't sleep because I'm dripping in sweat, and I would never be able to do my job. So symptom relief is really important. And then the long-term benefits of hormone treatment. So reducing the risk of heart disease, osteoporosis, bowel cancer, Alzheimer's disease. So the protective part of this treatment is massive. So that's why I support and want to give women the right information about it.
I mean, HRT had a really bad rap, didn't it, around causing cancer, and there were lots of media coverage. There was lots of media coverage on HRT over the years, and I think women have become quite nervous and also confused because they didn't know if it was safe or not.
Yeah, that's right.
But you're saying now that it is safe, and there are studies that have talked to us a little bit more about that.
So, I mean, the big study that was done in 2002 was a multi-million-pound study looking at HRT treatment. And when you listen to the experts talking about it, actually that study should never have, the results of it should never have been released, because the women that were recruited into the trial were already women who were in their mid-60s. So they were quite, obviously a long way past the menopause. They had underlying health conditions. So they had heart disease, they smoked, they were obese, all the things that increase the risk of breast cancer. So the actual group of women that were recruited were totally inappropriate. And so the evidence that they suggested was not based on the right cohort of women. So it was really scandalous. And what happened was the prescriptions for HRT dropped massively during that time. And the number of women who died during the decade when that happened went up massively, primarily from heart disease. So what they've done now is they've reanalyzed the data from that study 20 years later. And what they've actually shown is that women who use just estrogen as their HRT, so if you've had a hysterectomy, say, and you don't need progesterone, and we can talk about what the hormones do, but in women who've used estrogen alone, they actually have a lower risk of breast cancer than women who have not taken HRT. Okay, so women taking estrogen have a lower risk of breast cancer. And that's from a study 20 years later. The risk when you use estrogen and progesterone together, and again, I was attending a webinar this week by a man called Avron Blooming, who's a breast cancer specialist. He's a wonderful man. He's done so much work. And what he has shown is that actually when they looked at the combination HRT group, the women that they compared them against, so what we call the control group, that group had already taken HRT, so their breast cancer risk was a bit lower. So the gap between women taking combination HRT and women who hadn't taken it, who actually had, was wider. So in other words, the information that we've been given has not been presented in the correct way. So we've been given misinformation. So really the evidence for breast cancer, what we think is that if you have breast cancer in your body, and look, 1 in 8 women there's a lifetime 1 in 8 risk of getting breast cancer. If you have a cancer there, HRT will not give you breast cancer. But if there is a tumor there that's not visible, then taking HRT might make that grow and become more visible, in which case it's detected. And what we know is that the death rate from women taking HRT is no higher. So HRT doesn't make you die from breast cancer more than it would do if you didn't take it. So it might make it grow more, but the actual death rate from breast cancer is not increased.
Gosh, that's fascinating. That's really, I mean, this is more than I certainly knew from my last conversation. And so there's obviously more data being uncovered about breast cancer in particular. Can we just, there's loads of questions coming in, as I knew there would be. Can we just do a quick summary of the different hormones of progesterone, the estrogen and testosterone quickly?
Sure. Yeah,
and then we'll take some of these questions.
Okay, sure. So estrogen is the kind of main male-female hormone produced by the ovaries. When your estrogen levels drop, so when your ovaries are starting to give up, which happens from, on average, the age of 45 onwards, estrogen levels drop. And that's what causes the bulk of the symptoms, particularly the hot flushes and sweats, the vaginal dryness. Estrogen protects your bones. So we give estrogen back either as a gel, a patch, or a tablet. We also need progesterone. So when you give a woman estrogen, it makes the lining of the uterus start to thicken. So in order to stop that from happening, we use progesterone to balance it out. So that's what the progesterone is for. Progesterone also, depending on which type you use, and we'll discuss that because I've seen a question about it, but progesterone can help you sleep. It can help with mood problems. So it's really good for anxiety. And then we use, quite often, increasingly now, testosterone. So women produce a lot of testosterone, actually. I think we forget about that. So testosterone helps with libido. It helps with kind of energy and drive and joie de vivre. So testosterone is another very important hormone. So they're the 3 main hormones that we would use in replacement therapy.
Okay. And quickly, before we get on to these questions,
sure.
Bioidentical hormones versus regular. I mean, there's been a lot of talk about bioidentical hormones.
Yeah.
What is the difference?
Okay. So I'm going to call them body identical hormones. Okay. So, and I'll explain the difference. So body identical hormones are hormones that are structurally exactly the same as the hormones that we make in our own body. And body identical hormones are widely available and any doctor can prescribe them. Okay. So they're available on the NHS. Those hormones are viewed to be the best tolerated, and the risks with body identical hormones are extremely low. And in fact, body identical progesterone has been used to treat breast cancer. Okay, so that's how safe these things are. Bioidentical hormones are still hormones that are structurally the same as the hormones we make in our own body, but they're made in specialist pharmacies. So they're kind of bespoke with a mixture of estrogen, progesterone, testosterone in a cream or a lozenge. They're a lot more expensive. They're not available on the health service. So you have to go to a private clinic and you may have a lot of blood work done. My personal view, and I know about both, is that it to me doesn't seem necessary to do that, because you can get exactly the same thing made or given to us on normal NHS prescriptions. It's the same drug, and I don't think they need to be so bespoke, because most women need a small dose of everything. So that's the difference between bioidentical, specially made up in a pharmacy that's not a mainstream, body identical hormones, widely available, made by the big pharmaceutical companies, and any GP can prescribe them.
Yeah, okay. So I must be mistaken then. So I thought bioidentical came from a plant base and the other one was chemical. Is that
No,
not
so they're
right?
all plant-based,
So
Stella.
they're all plant-based. Even
Yeah.
the body identical ones are
Yeah,
plant-based.
they're all
Okay.
plant-based. But then, of course, you know, you can't take yam or soy and then just either eat it or mush it up. It has to be made into something that can be absorbed through your skin, which is why it has to go to a pharmaceutical company. I think the reason this all happened was because the first type of hormone that was made was the first type of estrogen was made from pregnant mare's urine. So it's called Premarin, pregnant mare's urine. And when women became more aware of this, they didn't want to take something that was made from pregnant mare's urine. They wanted something more natural. And so came along this industry of saying, well, these bioidentical hormones are completely natural, therefore it's different, but it's not. It's the same thing. And in defense of Premarin, although it is made of pregnant mare's urine, I've had patients who've taken it for years and it's difficult to get hold of now, and they don't feel as well as they do on other hormones. So I think, you know, it got a bit of bad press, but you know, you don't get pregnant mare's urine and drink it. You know, it's all carefully made, but that is the difference.
Okay, thank you for uncovering that. There's, as you say, there's a big debate about that, and there is a big industry around bioidenticals. Okay, let's come to some of these questions. There's we'll start with the Mirena, which I personally know all about. And again, as a backdrop, I have resisted the Mirena for years, and then I just had to have it. I just had to have it. Otherwise, my life was not great. I was suffering, and it has made a world of difference to me. Thank you, Stephanie. Okay, so let's talk about it. What are the advantages?
Okay, so Mirena it's an intrauterine, it's called an IUS, an intrauterine system. And it's what we would have previously called a coil, which I think is a terrible name because it's not a coil at all. Coil to me always, I imagined a bed spring or something like that. But in fact, it's a tiny T-shaped plastic device, no more than an inch long, less than an inch actually. And it's inserted into the uterus. It's a bit like having a smear, same sort of procedure, but they put this through the cervix and into the uterus. I've got one as well. I love my Mirena. Mine does need to come out, but anyway, that's another story. So what Mirena does, Mirena has got a little tiny bit of progesterone in it. So it's inserted into the uterus, and it's primarily been used for women who are having very heavy periods. And it's meant that the number of women needing to have hysterectomies has gone down by at least 90% because it's so effective. So for women in the perimenopause, and many women in the perimenopause will start having horrendous bleeding, which is so debilitating. I honestly don't know how some of the women I talk to, I don't know how they put up with it. So you can have this Mirena fitted, and then the progesterone in it, the function of progesterone is to make the lining of the uterus very thin. So the lining gets thinner and thinner and thinner, and the majority of women will stop having periods altogether, alleluia, or you might have regular periods but less heavy, or you might get irregular bleeding. So number one is it really helps with bleeding. Number two, it's a very effective contraceptive. And I think women in their 40s and early 50s think they don't need contraception, but you do. So Mirena can be left in for 5 years, which means you don't have to worry about contraception during that time. And the third function of it is that it's very useful on top of that for HRT. So if you've got the Mirena in, it means the lining of your uterus is protected against the effect of estrogen use. And so you can just have the Mirena and then just have a little bit of estrogen top up, and it lasts for 5 years.
Okay, yeah, it's definitely changed my life. So a question from Jane: what if you can't take HRT because of previous DVT?
Okay, so if you've had a previous DVT, you can't take oral HRT. So there are essentially two types of HRT: oral, where you swallow a tablet, and then what we call transdermal, which is through the skin. Your estrogen goes through the skin. When you swallow estrogen as a tablet, it goes through your digestive system into your liver, and it activates clotting mechanisms. And therefore, if you are very prone to having a clot, or if you've had a clot and you take oral estrogen, you are at very slightly greater risk of having another clot. If you've had a DVT, you can use HRT, but you have to use the estrogen through your skin, because when it goes through your skin, it goes straight into your bloodstream. It doesn't go to your liver, and therefore it doesn't activate clotting mechanisms. So there's no reason why women who have had any sort of clotting event, why they can't take HRT, but it has to be through the skin. There is no greater risk at all of any clotting. So you can take it, Jane.
That's great advice. Thank you. Lisa asks, this is a really good question. I've thought about this. I took bioidentical hormones for many years and have just stopped, and I'm now having all the symptoms. Does this mean I should take them for the rest of my life? Because that's a really good question. At what point do you stop taking them?
Okay, that's a very good question. Thank you, Lisa. So what we know is that 60% of women in their 60s will still be having menopausal symptoms. 60% in their 60s. That is a lot. And I see women in their 70s and in their 80s who are still having symptoms.
Wow. What kind of symptoms, sir?
It's often hot flushes and sweats.
Okay.
Joint pains, brain fog. They're the main ones in the older group.
Okay.
So many women are still having symptoms much later on. And what happened historically was that for some reason, and there was no medical evidence to support this, women were told that you can only take HRT for 5 years and then you have to stop. So what might happen is they would start HRT when they're 50 or early 50s. 5 years later, they'd stop it. So they were 57 or 58. Then they were told to stop it. And then they had menopausal symptoms because they were going to be having menopausal symptoms anyway. So it doesn't mean that if you take HRT, that then you're just delaying the menopause. And when you stop it, all the symptoms come back. If the symptoms are there when you stop it, you would still be having those symptoms anyway. So for me, I know that if I didn't take HRT, I would, and I've taken it for more than 5 years now, my symptoms would be, I would not function. So I'll carry on. And in fact, you can carry on taking HRT until the day you die if you want to do so. Okay, so you don't have to stop it. If you were to develop a condition that meant that you were not able to take it, then so be it. But actually, you can continue to take HRT because the benefits of it far outweigh the risks. That's the key thing. And just to reiterate that you're 7 times more likely to die of heart disease as a woman than breast cancer in every decade of your life from the age of 40. And HRT probably reduces the risk of heart disease by 50%. So what you're doing is you're protecting yourself. So you don't have to stop taking it. If people want to reduce the dose or stop taking it, that's absolutely fine. But I would normally say you just don't stop it suddenly, just reduce the estrogen dose by half and so on, and speak to your doctor about it. But many doctors are not happy about women staying on HRT, but that is because they have not looked at the evidence.
Okay.
Or they are not a woman and they have not had the symptoms.
That's usually the case, isn't it? Okay. I think there's a lot of resistance to just continuing to take a drug, in whatever format it is, especially with people who are big into preventative health.
Yeah,
there is that kind of thought around, oh, but I'm taking a drug, what, if I can help myself not do that.
Yeah, of course.
So there is I'll come to your question, Karina, in a sec, but there is a question from Marie which says the pros and cons of that. So if you don't necessarily have symptoms, would you say, what's your recommendation around that? Would you even take them?
Well, I still think it's about having the information and making the decision for yourself. So if you don't have symptoms and you feel absolutely fine, then yeah, sure, you don't need to take it. The other thing I would say, Stella, is this is not a drug.
Right.
I do not perceive this to be a drug.
Okay.
It's simply putting back a very small amount, maybe a fifth or less of what was there before. So that's my view of it. It's something, it's not really I know it's made by pharmaceutical companies, but it's not a drug.
Well, you're framing that for us, which is good.
Yeah.
We're framing that because I think of it as a drug.
It's a drug.
I'm putting back something which, you know, in the old days, you would have been dead by 50 anyway. So you're putting stuff, you know, you're putting hormone back in. Yeah.
But I think, yeah, if you're not having symptoms, and look, I'm not suggesting that everybody should take it, although I think because I know what the benefits are, then once you know what the benefits are, then I think it's up to us as individuals to decide whether it's something we want to do. And in a way, for women who have not had any symptoms, then they don't maybe get the benefit of getting or seeking out the information about what the health benefits are to them. So, you know, if you know that you can reduce your risk of heart disease by 50% and you're 7 times more likely to die from that you'll reduce your risk of getting osteoporosis, of Alzheimer's disease, of bowel cancer, then if you know that, then even if you're not symptomatic, it doesn't mean that you can't take it. But 80% of women will get symptoms. And what I see a lot is people come to me and they say, they think, and that, you know, they'll make an apology and say, well, you know, I shouldn't really be doing this. But actually, if they do use HRT, when they come back to me, they feel so much better that they don't realize that they've been suboptimal. And that's how I felt. I thought I was okay. The reason I've done all this extra postgrad training and stuff I swore I'd never do over the age of 50 is because I feel great and I can do it. That's why I'm doing jazz singing, playing the piano, all these things, and doing a very busy job. I mean, I push myself to the utter limit. I wouldn't be able to do that otherwise. So I want to make the most of my life and feel as well as I can. But also, I respect the fact that not everybody wants to take it, and that there are, and it should never be seen in isolation. You don't just take HRT and then sit on the sofa and eat crisps.
Yeah, absolutely. Thank you for saying that, because that's important too. And I just got to say at that point, when I came to you, I was perimenopausal and I had high estrogen levels and low progesterone, and you gave me the progesterone, and it changed my life, how I felt within myself, you know, much more relaxed. My body was relaxed. I could sleep better. All those things that I had normalized. I thought it was normal to be that way. And it wasn't until I saw the difference that I was like, this is what I've been missing. I've normalized feeling rubbish, basically, and thought it was okay. So thank you for that. Right, coming to Karina's question, which is about history of breast cancer. Yeah. Will HRT be allowed? And would it make a difference if it was a triple negative cancer, so not hormone related? I don't know.
Yes, so you can use HRT if you've had breast cancer. It has to be, obviously, and we give HRT to women who've had breast cancer. If it's a triple negative cancer, it means it doesn't have any receptors for estrogen or progesterone on it. So it means it's not hormone responsive. So yes, you can do, Karina. You would almost certainly need to go to a specialist menopause clinic. The other thing is, I've been reading a book, which I haven't got in front of me now, by this chap, Avron Blooming, and I would highly recommend this to Karina, called Estrogen Matters, or to, in fact, any woman should read this book or find Avron Blooming online and listen to one of his webinars. He talks about the data, and his wife and daughter both had breast cancer. He's a breast cancer specialist, and they both have taken HRT. So yes, you can do. And in fact, when you listen to the careful evidence, the risk of recurrence of breast cancer in women taking HRT is negligible. The women who've had breast cancer who don't take HRT tend to die prematurely of things like cardiovascular disease because they've been estrogen deficient for so long.
That's fascinating. It's fascinating.
Mm.
We don't really hear, we hear so much about breast cancer. We don't really hear about heart disease.
Yeah.
For women, we don't hear about that being a big, mortality factor. Okay, Caroline, when would you advise going on HRT? After a year of no periods, or before that? I haven't had a period, but she has nighttime.
Okay.
Really have.
That's a great question, Caroline. Thank you. So you can start taking HRT from the minute you become symptomatic. So it is a myth that you have to wait for a whole year since you've had a period. And I've seen women who've been told by their GP, you have to wait a whole year. That's rubbish. So you can start taking it as soon as you become symptomatic. And to get the full effect from taking HRT, you really want to take it within 6 years of your last period. So to get all those benefits for the heart, the brain, the bones, and so on. So yeah, if you're symptomatic, go and speak to your GP.
Okay, great, thank you. Lorraine asks about, she's had the Mirena, bliss, yes. GP insisted removal of coil at 53. Her periods have resumed, last 14 days plus days, very erratic. Been on HRT. Does this stop?
Have another Mirena.
You just say put another one in.
53. That might go on for another 4 years.
Okay.
That's what, if she started having periods lasting for 2 weeks, I mean, you have to take a view, don't you? You don't know how long, they might stop in 6 months. So she could do that and see how she feels and be prescribed HRT. But HRT doesn't necessarily stop all this heavy bleeding. And you and I know that you don't want to put up with that for too long. Yeah. So that's what I would suggest for her. Yeah.
Okay. So Lorraine, go and ask for the Mirena to be reinserted. Okay. Maureen, you see this question? Would you tell me, please, if it's worth starting HRT, kilovans, estradiol? I don't know what this is. I'm sure you do. If you're 55, still having a rare period every 4 or 5 months. Some symptoms such as sudden loss of belly fat.
Is the question whether or not to continue taking it?
Yeah, just saying, if it's worth starting it. She hasn't taken any HRT, so she
definitely. If you're
I think she's put the question further down: is there something more natural? So again, she has this aversion. Similar to what I have.
Yeah, sure.
Yeah.
I mean, look, there are other things that you can do which will relieve your symptoms, and the things I recommend to women, and there's lots of information about alternative treatments, and I'll send you the link, Stella, to the British Menopause Society website. But acupuncture can really help with menopausal symptoms. I recommend people to take magnesium because that helps with sleep and anxiety and muscle symptoms. Vitamin D is good for immunity and general well-being, and so they're the main other things I recommend. You can take red clover, and there's all sorts of other things you can buy, but the evidence is that they don't actually help much. That's the clinical studies don't show much benefit. And something like black cohosh, which has been very popular for treating menopausal symptoms, you have to be very careful with that, because if you buy the wrong one, it can cause liver damage. So the issue with alternative remedies is that nobody tests their safety. And I've seen women who have taken soy products and phytoestrogen, so the plant-based estrogens, who have developed abnormal thickening of the lining of their uterus. So, I think, yes, there are natural ways that will help you. And of course, we should all be doing exercise. We should all be getting good sleep. We should eat a healthy diet. We should be doing resistance muscle. We should be doing all of that stuff as well. And there are other treatments that will relieve symptoms, but they won't give you the long-term benefits. So for this lady who's asking about going on to HRT, who's symptomatic, yes, of course, do, if you're getting hot flushes.
Yeah. I mean, we've had these conversations before. I think you can complement with different things such as acupuncture, Chinese medicine. Yeah. There's a lot of stuff that you can complement alongside, but it may not get rid of your symptoms easily and quickly. I'm just talking from personal experience because I have tried this. And for me, the thing that really just made a difference, an immediate effect to my very debilitating symptoms was HRT. And I really struggled with the concept of taking it, you know, because it just didn't feel right to me. I wanted to control everything naturally until I had to kind of surrender to the fact that I couldn't with this. And that's
the thing is, Stella, that I meet women who, I saw a lady not that long ago who hadn't slept for 4 years, right? 4 years. And she said to me, I'm really, you know, I know I'm not that bad. I'm not that bad. And I've waited for so long. And I've not slept for 4 years. 4 years. I mean, imagine the health, the harm you do to yourself after 4 years of not sleeping. And nobody should apologize or feel that they're giving in or that it's doing something wrong, that we should all just woman up and, you know, just suffer because that's what we're meant to do. I mean, I was down doing a talk somewhere, this was a couple of years ago, and I was in the lounge of this place waiting to do this talk. And there were 3 women sitting having tea. And they obviously didn't know who I was, but I was near enough to be able to hear what they were saying. And they were, I would say they were in their late 50s, early 60s. And one woman said to the other, oh, I'm here because I want to be able to share this information with my daughter and I'm really interested. And another lady said, well, I mean, I think it's just a waste of time. She said, you know, to be honest, by the time you get to 50, you should be kind of taking it easy and not putting yourself under so much stress. And I thought, my God, if this is the message, I was horrified. I couldn't believe it.
Yeah. Well, we believe life begins at 50, don't we, Steph?
Exactly. Plus with our scales and arpeggios. Good Lord.
Yeah. There are some questions here about GPs. No trust in GPs. My GP won't prescribe HRT. She says I am high risk of heart attack and stroke. What are my options? So these are obviously GPs who don't have the knowledge. No. So what are people's options around that if their GPs are just not either trustworthy or? Well,
I would. So the first thing is that if you're high risk of heart disease, diabetes, and so on, you should be on HRT because it reduces the risk. And the consultants that I work with, who are cardiologists, run special clinics for women with heart disease and menopause, and they put them on HRT because it reduces the risk. If you've got heart disease, the only thing is you should use it through your skin and not swallow it. Okay.
But what do they do if their GPs are being uncooperative?
So you either go and see another doctor, or you see a menopause specialist.
Okay.
Or you print off the NICE guidelines, which are the guidelines which tell you about how to prescribe hormones safely in women, and you give it to your GP in advance of your appointment, and you say, here is the evidence. This is what I would like. But I would suggest if you're getting that sort of advice, you're not going to get anywhere. You need to talk to someone else.
Yeah. Okay. Thank you. Let's see what else. Oh, this is a good question. Are there links between perimenopause and thyroid disorders? So I went to GP with perimenopausal symptoms and got a diagnosis of hyperthyroidism and was told I am perimenopausal.
Okay, so thyroid problems often occur at around the same time as the menopause. Okay, so it's not that one causes the other. It's just that they tend to happen at a similar age. So interestingly, I saw a lady who I met. I'd never seen her before. We did a Zoom consultation during lockdown she'd made an appointment to talk to me about the menopause, but I noticed even on Zoom that she did not look very well. And so we decided to deal with her not being very well. And actually she had the most overactive thyroid I've ever seen in anybody in my career. And it had been triggered actually by COVID, which was really interesting and a bit worrying. But so and she was also menopausal, but we dealt with the thyroid problem first. And then now we're doing her HRT, which she needs. But symptoms of the perimenopause and thyroid disorders can mimic each other, but it doesn't mean you can't treat both. Okay, so if you've been found to have a thyroid problem, treat that, but that doesn't mean you can't treat your menopausal symptoms as well. Because, as I say, the symptoms can be very similar.
But by treating the menopausal symptoms, can it help the thyroid?
It might help the thyroid symptoms, but it won't help. It won't treat the underactive thyroid is a bit like taking HRT. It's just putting back a bit of what should be there.
Okay.
Yeah.
Okay. What is your view? Yeah, we talked about it. You're using diet and supplements and reducing or addressing specific symptoms. I mean, I personally do that in addition to.
I think do that as well. You know, avoid refined sugars, eat, you know, complex carbohydrates. So I think eating a healthy diet is a given. We should all do that. Don't drink too much alcohol. You know, I've noticed people's alcohol consumption seems to have gone up a lot during lockdown. And if you drink more than 14 units of alcohol a week, then your risk of breast cancer is much higher than it is than if you take HRT. So be careful of that. So I think we should all be doing those things as well, because that enhances the well-being and our longevity as well.
Yeah. Maybe we'll do a session with a nutritionist in the future about that, actually, about how to eat during midlife and beyond to help. If you have the symptoms, can you go on HRT in your 60s?
You can do. So if you're symptomatic in your 60s, and I met a woman not that long ago who still goes to bed at 65 with a towel underneath her every night because her night sweats are so bad, and nobody had ever offered her HRT. And, you know, this was a woman who hadn't had a good night's sleep for 15 years, which is dreadful. So you can use HRT in women in their 60s. If you're going to start HRT later on in life, you have to be a bit more careful to do a good cardiovascular risk assessment, because if you start HRT much later on in life, if you take it orally, which I wouldn't do in somebody in their 60s anyway, but if you start it later on in life, you may increase their risk of some sort of heart event if they haven't had hormones for, say, 15 years. But we do treat women like that. We give them estrogen. We give it to them through their skin because it's the most effective way of relieving their symptoms.
Okay. But if you don't have symptoms in your 60s and you've never had HRT before,
I wouldn't recommend it. No. What I suggest, so if I meet women, and I do, who come along to talks I've done and say, oh my God, you know, I've missed out on this. I'm really worried, particularly about bone disease or preventing osteoporosis. What I say to those women is have a bone density scan and make sure your bones are okay. Because if you live into your 80s, which hopefully most of us will do, your chance of having a fracture is so high. 1 in 2 women will have a bone fracture. Very, very high. So make sure your bone density is all right and have a cardiac risk assessment. So have your blood pressure checked, have your cholesterol levels checked, have yourself checked for diabetes and pre-diabetes. They're the things I would do, because that's the bit you've kind of missed out on.
Great, thank you. A question from Jill. How do you know when it's the right time to start discussing a first sign of symptoms perimenopausal? Because I think this is the thing, in this country, we don't do regular bloods. We don't do regular blood tests to know where we are.
Yeah.
And so, and I know on the continent that happens quite frequently. So what would you recommend around people actually just knowing?
Yeah, I mean, the thing with blood testing in perimenopause is that it's very unreliable. Okay. Because by definition, if you're perimenopausal, sometimes your hormone levels will be fine and sometimes they won't. And it just depends when you take them. So in women over the age of 45, you don't really need to do blood testing. I do sometimes, it depends. But over the age of 45, if you've got symptoms, then that's the time you should start opening up the discussion. And there is something, Stella, called the Green Climacteric scale, which is a scale. You can download it from the internet. It's green with an E on the end. Climacteric means menopause. So green climacteric scale, and you tick the boxes for the symptoms that you have. And what you can do is, I would say to patients, print it off, tick the symptoms you've got and show it to your GP. So it's more about symptoms than relying on blood tests to give you a diagnosis. If you were under the age of 45, and definitely if you were under the age of 40, you would need to do it, because we need to know whether or not you need to take hormone treatment. Because if you're a young person getting menopause, you definitely need to take HRT.
Okay, so if you're below 45 and you're having symptoms, then bloods are better than that. Green. Okay, I'll get this information. I can share it afterwards with the recording.
Yeah.
And with people. So does HRT increase my? We talked about breast cancer and okay, resistant. Again, we've got back to the GP. Oh yeah, the traditional acupuncture can help with heavy bleeding. Yes, I've found that too.
Yeah.
Yeah, talk about changing your GP. Julie says, just sharing with us, I have been on HRT for 16, 17 years since I was 35 years old. Wow. When my period stopped, it has been protecting my bones and has helped me stay in the osteopenia category. So let's talk a little bit about osteoporosis, actually, because that's a good subject and something that we're at risk of post-menopause, right?
So yeah, with
that risk of it.
Yeah, I mean the bone density drops dramatically in the first few years after menopause, and then gradually decreases over the years. And I say 1 in 2 women over 50 will have a fracture. And for older women who fall and break their hip, there's a very high death rate within the first year after that. So, you know, as women, we do live longer than men, but our last 10 years of life are plagued with debility. So strokes, hip fractures, osteoporosis. We see these old lady walking around, you know, with severe curvature of the spine. So osteoporosis is a real problem, and it's totally preventable, provided that, you know, you've got it. So say after the menopause, your bone density will drop. So I would normally recommend women to have a bone density scan. You won't very often get it on the National Health Service, but I use a clinic where you pay for it. It's about £60. So it's not expensive. And at least it gives you an idea of where you're up to. And I've certainly diagnosed a lot of people with osteoporosis, including a couple of men actually, but diagnosed osteoporosis in people who, and we would never have known that they have it. And they're not, but when you look at them, you think they're not high risk candidates. They're generally women who have not taken HRT. So bone density scan is a good idea. Either you can start have it, you know, at around early 50s, just to get a baseline of where you're up to. If you're taking HRT, don't need to worry about it. And the other thing about osteopenia, so your bone is either normal, osteopenia, or osteoporosis. So osteopenia is the middle ground. But actually, most women who fracture their bones, osteopenia is not considered to be a significant risk factor for that. So many, many women will have osteopenia. So it means your bones are not quite 100%. But I think it just focuses the mind in terms of, you know, am I doing enough weight bearing exercise? Because that's really good for your bones. It's really important to keep your muscles strong. So bone health is very, very important. HRT is the treatment of choice for women who have osteoporosis if they are under the age of 60, not the other much stronger drugs, which have a lot more side effects.
Right. Thank you. This memory loss is coming up.
Yeah.
A lot. I'm going through that now. Some days I remember the most useless facts, and then and I can't remember what I did 2 hours ago. Or for me, it's like words. I forget words. So I think this is very normal. This is from Cara. It is normal. And this is one of the reasons we wanted to do this session today. So women can feel that, you know, you're not strange. These aren't specific conditions that are just happening to you for a worrying reason, that this is actually quite a normal thing, right?
Yeah.
Memory loss. Yeah. And then again, HRT could help with that. Let's see what other questions here. A question, Lubna. After a hysterectomy, I took Everel for 6 months, but I didn't feel any difference and decided to come off HRT. How long should you wait for things to take effect?
Yeah, that's a good question. I mean, if you've had a hysterectomy, sometimes they take your ovaries and sometimes they leave them. So if you have a hysterectomy and they leave your ovaries, the age of your menopause is normally brought down by about 5 years. So, you know, if you have a hysterectomy at 50, then you're losing 5 years of ovarian function, basically. If you're not getting any symptoms, the reason you're taking HRT then is, especially if they've taken your ovaries out, is that you've suddenly gone from having estrogen to having none. So it's purely there for protection. And remember, for this lady who's had a hysterectomy, if she uses Everel, which is an estrogen patch, so the estrogen goes through your skin, her risk of breast cancer is lower than in anybody who's not using HRT, and she's got all the health benefits. So if you've had a hysterectomy, you're in the best possible position if you then use a bit of estrogen. If you're very symptomatic with hot flushes and sweats, the symptoms can go very quickly. My hot flushes went within about 3 days of using a patch. So the symptoms can go very quickly, but we normally say to people, you need to give it 2 or 3 months to feel the full benefit from it.
Right. We're running a little bit over, but I think there's some really valuable questions if you're okay for carrying on.
Yeah, that's fine.
Yeah. Does HRT have any effect on fibroids?
Okay, so that's a good question. So fibroids are sort of muscular lumps, if you like, that grow in the uterus, and they can cause very heavy bleeding. That's often why women around the time of the perimenopause get very heavy bleeding. It's because they've got fibroids and they might not have known about it before. So yes, you can use HRT with fibroids. If you've got very big fibroids, you might just want to watch them a bit carefully, because they may increase in size a bit. But actually the Mirena works extremely well for women who've got fibroids. That's why these women are not having hysterectomies now, which is what they used to do. So yes, you can have a Mirena, which controls the bleeding. And then if you're symptomatic, you would use a bit of HRT through your skin.
Okay, great. Thank you. Yeah, somebody's asking me how it changed my life. Basically, I was bleeding constantly. I had become very anemic, and I was resisting having the Mirena. I had very low progesterone levels and very high estrogen levels. Eventually, and then I had some fibroids, little fibroids, and then I had lining around inside my uterus. Yes, inside my uterus, which is kind of the opposite of endometriosis. And so, yeah, my quality of life was suffering a lot. And I tried everything. I tried through diet, I tried through supplements, I tried everything. I had acupuncture, which helped a little bit. The only thing that really stopped it for me was having the Mirena applied. And that wasn't easy. I've got to tell you, the first 6 months of that Mirena was difficult for me. I was cramping, I had pains, I was bleeding, but with Steph's guidance, I kind of continued with it. I was tempted to remove it. I wasn't feeling great with that, but Steph was like, it's normal, just, it's okay, keep going. And then eventually it all stopped. And now I feel 100 times better. So that's my story. Osteoporosis, we've talked about osteoporosis and osteopenia. I'm not keen on medicine. What are the alternatives? What lifestyle can you recommend? Anything you can do for osteoporosis which isn't HRT related?
Yeah, I mean, exercise is the most important thing, actually.
Mm-hmm.
So muscle building, resistance exercise is the number one thing. Make sure that you have enough calcium in your diet, but you shouldn't take calcium supplements unless you have osteoporosis. So I don't recommend doing that. Vitamin D may help also with bone strength.
Okay. Mariana asked, if you don't recommend relying on blood tests like HRT, how do you decide on the doses?
The dose, to be honest, it's pretty, you make a decision based on your patient, but it's generally a sort of, there's a usual dose which gives the vast majority of people, women, the symptom relief they need and the bone protection. So you know, you can sort of bespoke it, because things, the gels and the patches, you can use different amounts of it. So you can do that depending on the individual. And really what you want to do is use enough estrogen, particularly to control your symptoms. That's when you know you've got the dose right, not really by blood tests. Your patient will tell you. If someone comes back and says, well, I'm still having hot sweats at night, use a bit more estrogen. And so that's your barometer, is how you feel.
Yeah. Now, there's a couple of questions on depression and anxiety. People have been on antidepressants and wondering whether, this is from Shelley, wondering whether she should move away from antidepressants towards HRT. She's now saying, gosh, is this really from my hormones?
Yeah. I mean, I see women in this situation, and what we do, again, depending on the individual circumstances and on their symptoms, is I might start them on HRT, and then we just gradually wean them off antidepressants. I wouldn't stop one and go straight on to another. You have to, you know, you have to be a bit careful about, if you've been on antidepressants, you have to come off them a bit slowly. But I've certainly done that, reduced one and brought the other one up, and it's worked perfectly well. I mean, the nice guidelines, which you can find online, by the way, someone asked a question, if you just look up NICE guidelines menopause, say that the treatment of choice for women of perimenopausal age with depression or mood disorders is HRT, not antidepressants.
Right. Interesting. What does DHEA mean?
So DHEA is a precursor to testosterone. It's another sex hormone, and it's used a lot in Europe. People take DHEA a lot. In the UK, you can buy it as a supplement, but I think you have to be a bit careful with DHEA, because it's broken down into estrogen and testosterone, and if you take too much of it and you get too much of the testosterone, then you can start getting testosterone side effects, which is, you know, feeling a bit angry and spotty, and some mood changes. I've seen women for whom that's happened. And there are clinics where they'll check your DHEA levels, and if it's really low, you can take a small supplement. So it is something that you can buy. Sometimes it can really help with energy and so on. But personally, I do occasionally give DHEA to women, but I think you can get the same benefits from using estrogen, progesterone, and testosterone. And with those, we know how much to prescribe without causing symptoms, because we've got data to back it up, and we don't for DHEA.
There's just lastly, I'll just cover this. There's some comments about these supplements, you know, Menopausal and Woman and Cytoplan, bone support. You know, what's your view on them?
I mean, I think that they all have a place. So, you know, some of them they've got B vitamins and vitamin C and vitamin D. So it's all the things that will help you with energy levels, and sometimes they can relieve symptoms a bit, but there's not evidence to support that. So I take a few supplements myself, but I don't take a lot, because I'm using hormonal treatment which controls my symptoms, and plus it gives me all my other long-term health benefits. But yeah, sure. I mean, there are lots of things available which have a part to play in our general overall well-being.
Yeah, I agree. Good, thank you. I think we're going to wrap it up now because we're 11:10, and I know you've got plans.
Piano practice to do, Ella.
You've got what? Piano practice. There you go. Very good. So thank you everybody for being present and for your great questions, Steph.
Yes, thank you.
Huge thank you for your time and your expertise and your matter of factness, and just being a sensible voice really throughout all of this, because it's such an overwhelming subject, and you know, one that we all have different symptoms with. And so thank you.
Pleasure
for your time.
Have a nice weekend, everybody.